Hey, future respiratory therapist. Farhan brings a question to me here talking about desynchrony or asynchrony on the ventilator, and asked if I could lay out the different types. Now, there's so many different types of asynchrony that the answer is no. I can't lay out all of them, but I will give you very briefly here, keep it as short as I can, the most common, okay? And the most common have to do with the time leading up to before a breath, and then types of asynchrony during a breath. Okay, so if you go online and just search for dyssynchrony, you will pull up all types of studies over early inspiratory phase dyssynchrony, late inspiratory phase dyssynchrony, expiratory dyssynchrony, pre-breath dyssynchrony. I'm just going to lay out the most common ones to you that you're going to see on a regular basis, okay? Now, also this has to do with the fact that we're going to talk primarily about volume control ventilation, which if you live in my area, that's primarily the mode of mechanical ventilation. Now, if you live in an area to where it's more pressure control ventilation, then your dyssynchrony looks different. The problem is still the same, it just looks different, and we'll touch on that also, okay? Excuse me. So, what we're going to talk here first is, I'm going to draw some waveforms up here. So we've got our pressure, and we have our flow. Okay, those are our two waveforms. Volume comes into play also, but it's not a big indicator in your asynchrony world, okay? So when you're talking about asynchrony, you're usually talking about flow patterns or your pressure waveforms, okay? So if you have a PEEPA 5 set and you have this going along and it dips and then comes up and then comes up and delivers a breath, this dip right here tells you that your patient tried to initiate a breath, but it wasn't recognized, which means the diaphragm dropped, the intrathoracic pressure dropped, that created a drop in your pressure waveform, but a breath wasn't given. There was no breath given here, okay? And so this would be indicative of a failure to trigger, which means your sensitivity is not set correctly. Okay, so you need to make your ventilator more sensitive. Adjust your sensitivity so that the ventilator recognizes when the patient is trying to initiate a breath. If you see that once or twice on a waveform, then it says, hey, the patient's trying to take a breath and they're not getting one. Okay, now obviously because this is a square waveform, I'm talking about pressure control here. But even if it's volume control, you can see the same thing. You get this dip and then up, and then you get a slow rise in your pressure. That would be a volume control breath. It doesn't matter. What matters here is that the patient tried to initiate a breath but didn't get one. So that's the first asynchrony you recognize. When your patients are on a ventilator and they want to take a breath, you should allow them to get that breath. Don't let them sit there and struggle, because it's going to create more problems for you down the road. Okay? And the key to mechanical ventilation is to make the ventilator breathe like the patient, not the other way around. We always think like, well, the patient's bucking the vent. Yeah, the patient's bucking the vent. You know why? Because the vent's not meeting the patient's needs. It's not doing what the patient wants. So you got two options. Either make the vent do what the patient wants, or knock out the patient's drive, which studies have shown are never the best way to deal with asynchrony. They don't lead to shorter vent days. It doesn't lead to shorter ICU days. And so increasing sedation to create synchrony from a respiratory therapy standpoint should not be your first goal. Your first goal should be to let me see if I can make this ventilator do what the patient is wanting to do. Okay, so that's the first thing I leave there. So this here is an example of a failure to trigger a breath, and you need to adjust your sensitivity. Okay, now I'm going to erase this. Okay. Now the next two examples I'm going to give you, and I'm only going to give you 3 examples because clinically what I've found is that those 3 examples are typically the most common. The first one being failure to trigger a patient-triggered breath. The second one is early breath. So after the breath starts, you see this very slow, you see this anomaly on your pressure waveform. Now remember, we're in volume control. So the breath comes in, it comes up, and it gives, right? Now, in volume control, flow is set. So if flow is set, then this isn't going to change. So what's going to change is going to be what you see on your pressure manometer. So your pressure comes, the breath starts, and then you see this dip before it falls back down. This dip right here tells you that your patient's diaphragm is dropping faster than the flow that's coming from the ventilator. So this patient is flow hungry. This patient's diaphragm, they're asking for more flow than what is coming from the mechanical ventilator. So what you need to do in this case is increase the flow. Now if you think about this should make sense. Why does the pressure waveform dip? Well, it dips because the patient's diaphragm is dropping faster than the flow of gas coming into the lungs. If the diaphragm drops quicker than that, then you get a greater drop in intrathoracic pressure, which pulls this pressure down, and you get this dip, okay? And that is an indication of an inadequate flow. This patient is flow hungry, okay? So in this case, you need to increase the flow. I've increased the flow literally, guys, no joke. Some people are probably going to watch this and go, this guy's lost his mind. But if I told you that we had a patient with a severe flow hunger problem, this is exactly what we saw. It was more exaggerated than this, but we had a flow hunger issue. We were set on 60 liters per minute. The patient was breathing 40 plus times a minute. They were not happy. This was the pattern every single breath. So what we did was we increased the flow. We took it from 60 to 70. We went from 70 to 80. We still had this. We went from 80 to 90. We still had this. Now, they was getting better each time, but it wasn't resolving the issue. Respiratory rate still greater than 40, and this every single breath on the mechanical ventilator. So, what do? We turned the flow rate up from 90 to 100. We ended up getting all the way up to 145 liters per minute. And when we did, on the next breath, we saw this. Okay? So we went way up on the flow, but this is what we finally got. We finally met the patient's inspiratory flow demands. Okay, now we settled it, we left it there. Okay, now what you're thinking here is like, didn't your pressures increase dramatically because you went from 60 liters per minute up to 145 liters per minute? Didn't your peak pressures go through the roof? And the answer is no. And the reason it's no is because your diaphragm is dropping so fast that there's no that's part of the pressure equation, is the intrathoracic pressure. And so we were finally meeting that to get a normal pressure waveform. And our pressures went up literally by like 3 to 4 centimeters of water pressure. So before, when we were at 60 and we were getting this severe drop in our pressure waveform, we were getting peak inspiratory pressures like 36. We increased the flow eventually to 145, and we had a peak inspiratory pressure of like 38. That's not that big of a difference when now you're meeting the needs of your patients. Now, here's what's interesting that happened. Within 30 minutes, the rate was down from 40 plus to the high 20s. Now, tell me we didn't do something good for this patient. We fixed their asynchrony. We made the ventilator breathe like they wanted, and they said, oh, thank you. I can finally rest and relax because the breaths that I'm receiving are fulfilling my needs. So thank you so much. So we got by the time we left, the patient was breathing 22 times a minute. We gave a report that night. We told him, we said, don't panic, but the flow rate is set now at 135. As the rate came down, we dropped the flow down a little bit. We were like, okay, we've caught them up now. And now let's see if we can turn it back. We were down to 135. When we left, we gave the oncoming respiratory therapist report. And we said, hey, don't panic, but the inspiratory flow on this patient is 135. This is no lie. The respiratory therapist told me, well, I like 60. And my comment back to her was, well, you may like 60, but this patient likes 135 right now because they're sick as a dog. I mean, they're sick. This is a sick patient. And they like 135. In front of us, she went over and turned it to 60. We came back the next day and did clinicals the next day. No lie. At the beginning of the shift, we took this exact same patient. We go back in there. Rate is back in the 40s. We see this again. What do? We do this right off the bat, and within an hour, we have them back breathing in the 20s. So, I understand that you understand that normal flows, excuse me, are 40 to 60 liters per minute, higher for COPDers. I get that. It doesn't mean that normal means normal for everyone. You got to step outside the norm sometimes and do what the patient is asking you to do. They can't verbalize it. They can only give you data to operate off of. And if this is the data you're getting, then make an adjustment and do something different. Okay? Now, like I said, we got them down back in the 20s, and eventually we were able to turn the flow back down less than 100, and the patient settled down. But when patients get flow hungry, just like you and me, if we go run a mile right now, or 2 miles, or 10 miles, we're going to have to compensate for that. I'm going to be breathing hard. If I run 1 mile right now, I'm going to be breathing very, very hard until I have, and the sensation of dyspnea goes away. So as it goes away, that inspiratory flow demand that this patient was requiring up to 140 will decrease, and you can adjust your flow setting. Okay? This is not MBRC world talk. This is real world mechanical ventilation management, which is what you're training to do. So learn to be great at it, okay? Now the last thing I want to show you is something a little different here. I'm going to erase this one up here at the top. Okay, so back here to our baseline graphics. So you got your flow graphic here. It's set on 60 liters per minute because that's what we set it on. And your pressure waveform looks like this. You get this big dip. Now this looks like a dip on the front side of it, but this is actually a rise in pressure on the back side. Okay? This is telling you that your patient is trying to end exhalation prior to when the vent actually is trying to end it. Okay? So this could also be a flow issue. This could maybe be a tidal volume issue. If your tidal volume is too big, then the patient's going, I don't need this much volume. And they're trying to exhale within the last 75% of the breath, and you see the diaphragm coming up and it pushes the pressure up. Okay? Or this patient could also be flow hungry like we talked about earlier. Okay? So in this case, you need to adjust it. You probably need to either decrease your tidal volume or increase your flow. Okay? Now the last one that I want to talk about looks something like this. The breath comes up and then dips down, comes back up, and then goes back down to baseline. Now, when this happens, you get an initial, immediately another breath happens. So your volume waveform will look like this. Breath goes up, down, comes back down, and then immediately back up. Okay? Now, when this happens, your secondary pressure waveform will go way up. Okay? Now what's happened here is that at the point in time when this breath was ending, another breath was triggered at that point. So the breath comes in, it's plateauing, and then you get another secondary drop in pressure, and then another breath has happened immediately. So you get what we call breath stacking. Breath stacking is something that I never saw early on in my career. And the reason I never saw it earlier on in my career is because when I first started, we were doing tidal volumes of 8 to 12 mLs per kilo. That's ginormous breaths. Here in 2019, we're doing average 6 mLs per kilo. Well, guess what? 6 mLs per kilo doesn't satisfy all your patients. So when you see this happening, what you're seeing is a patient that is volume hungry. And what they're doing is at the end of the breath, their diaphragm is still dropping. And they're going, I want more breath. But the machine, the vent, says tidal volumes delivered, cut off. Expiration time, cycle off. And at exhalation time, the negative drop and the continuation of the diaphragm dropping on the patient side of things immediately triggers another breath. So what you get is a little bit of exhaled volume and then immediately another volume. Now what's going to happen is this patient's peak inspiratory pressure is going to go way up. And it's going to go way up because instead of putting 400 mLs into this patient, because they immediately triggered another breath, they now have 800 mLs put into them. And that creates a higher peak inspiratory pressure. Your flow graphic looks the same because it's a set setting. Your volume graphic will show that your volume does not, it exhales a little bit, but then immediately becomes a baseline and delivers another tidal volume. Now what you're going to see is that this tidal volume is going to exhale way below baseline. And all of this gas below baseline is the remaining volume of this first breath. Okay? And this tells you that your tidal volume is not set adequately. Now the problem with this is that you have a patient who may be wanting a tidal volume in the ballpark of, let's say, 450 mLs. We have them set on 400. Their diaphragm is still dropping because they're wanting 450, but we're giving 400. Okay? The consequence to that is we get this steep peak in pressure, this steep increase in peak inspiratory pressure, which could possibly lead to barotrauma, just to give an additional 50 mLs to the patient. They want 450 mLs. That's how they're comfortable. You cannot tell the brain to breathe differently unless you sedate it and completely knock it out. If the neural drive to breathe is but you cut it off at 80% of what they're wanting, then they're going to trigger, if you're in assist control, they're going to trigger another breath. And what you get is this steep increase in pressure and this additional tidal volume. Now what they're going to get is another 400 mLs. So we're essentially giving now a tidal volume of 800 mLs. Where if we just tweak the tidal volume a little bit, maybe all they want is 430 or 450. Maybe 470. Maybe they want 7 mLs instead of 6 mLs per kilo. And that's not going to harm your patient, as opposed to this happening all day long. Because what you're going to do here is you're going to go in and you're going to do one of two things. Either you're going to troubleshoot and go, I think the patient wants more volume because they got this late drop in pressure, which is initiating next breath, and I think they're volume hungry. So let's try turning up the volume a little bit, and you're going to find that, just a few more cc's of volume solves this. Or you're going to go in and say, oh man, they're breath stacking, peak pressures are peaking out at 48, and that's too high. So I'm just going to turn my peak inspiratory pressure alarm up to 58 or 60. And you're just going to adjust an alarm. And that's that's not the right movement. Okay, that's not the right play at that time. Okay, you should never just adjust alarms just to be adjusting alarms so they don't alarm. If the vent alarms that you have set are set correctly, then if you have to adjust them, you should ask yourself, is there anything else I can do to make the ventilator breathe more like the patient wants? Okay, so Farhan, I hope this helps. I hope this answers your questions on asynchrony or desynchrony. If you guys see this in clinic, I would love for you to put a comment in about what you're seeing. And if you made any of these moves that I'm talking about, I hope you put them in there and say, hey, man, I'm glad this worked. Or, hey, man, this is what it looked like, but this didn't work. What do we do now? And we can figure it out together. Hope everybody's having a great day.